Okay, so welcome to this session on hypermobile Ehlers-Danlos syndrome and bleeding disorders. So I was originally asked to talk about connective tissue and bleeding disorders. Ehlers-Danlos syndrome is the most common type of connective tissue disorder, and it's what I specialize in. So we're going to talk about what the connection is. This is me. I'm a professor emeritus of physical therapy at Clarkson University, and specialized in chronic pain, hypermobility, fibromyalgia, headaches, and you can, my email is here. The slides are available. If you want the slides, just email me. And there'll be a scan code where you can find that information. I don't have any conflicts of, pardon? Oh, yeah, there's going to be a scan code in just a minute. So I don't have any conflicts of interest to report. I will be telling you about lots of educational resources that I have on my website. I don't make any money for any of that, so not a conflict of interest. So why does the zebra, if you're familiar with hypermobility, you've probably seen the zebra. You guys are ladybugs, we're zebras. Why zebras? Because most healthcare providers have been told, when you hear hoofbeats, look for horses, not zebras. Look for common things, don't look for rare things. And you guys of all people would know, sometimes we have the rarer disorder. And with hypermobility, it's the zebra, and you need to recognize that we're not the same as people with as horses. So I have a lecture series. I call it my Hypermobility 101 lecture series. So if anybody wants to learn about hypermobility, there are recording slides on my website, which you can get to with a scan code. And I do them live every week on Fridays. So if you want to come, you can ask me questions. Those are all available. And I'm actually going to add one on bleeding disorders, because after putting together this set of lectures, I have enough now for an hour's worth of discussion on bleeding disorders. I also have a website with a lot of handouts on hypermobility, chronic pain. You can get to it by this scan code or the other scan code. They'll all get you to one another, and my email address will be up there as well. My usual disclaimer is that the information is for general purposes and may or may not apply to your particular situation, especially you guys who have the added complexity of bleeding disorders. So you always want to check with your healthcare provider before you start any treatment program, and I can't diagnose or provide any individual medical recommendations. So the objectives for this session, to be able to list the common signs and symptoms of hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorder, and I'll explain the similarity and overlap between those. To describe common comorbidities, in particular, postural orthostatic tachycardia syndrome, or POTS, and mast cell activation syndrome, MCAS, because they will impact bleeding in particular. And then explain why connective tissue hypermobility is relevant when you're talking about bleeding disorders. In the next hour, we'll talk about ways to manage the hypermobility, where to get more resources, and some of the issues where hypermobility might change how you manage your bleeding disorder or supplement how you manage your bleeding disorder. So, spoiler alert, hypermobility is really common in bleeding disorders. And especially bleeding disorders of unknown cause. So if you don't have hemophilia or von Willebrandt's, there's actually a study that shows that 80% of women with bleeding disorder of unknown cause are hypermobile. And so it may affect some of you here, and that may be contributing to your bleeding disorder. It may contribute to why maybe your bleeding disorder is a little bit worse than your lab tests might suggest. And then from my point of view, bleeding disorders are really common in people with hypermobility. And I try to convince my colleagues that they should be looking for bleeding disorders in their patients. I've been presenting at bleeding disorder conferences for 3 years now, and I am amazed that I wasn't asking people about that for the past 20 years. But we live and learn, and now I would consider it negligent to treat somebody with hypermobility without asking them about bleeding. Okay. So you may have both hypermobility and a bleeding disorder, and that may be why. And I've heard a number of times at the conference so far, some people may have lab results at one level, but they bleed more than that suggests, and maybe hypermobility might be part of the reason. Okay, so Ehlers-Danlos syndrome is a set of 13 to 14 genetic conditions, and they are fundamentally abnormalities in collagen. Collagen is the stringy stuff that makes up connective tissue. I'll show you that in a moment. But some of the main symptoms of hypermobility or Ehlers-Danlos are stretchy joints. That's what you can see. Sometimes stretchy skin, poor wound healing, chronic pain, and easy bruising, POTS, which I'll define in just a moment. The one thing over here on the right where the increased risk of aortic root dilation, so your aorta swelling and having an aneurysm, actually turns out to not be more common in most of the forms of EDS. Oh, and where I have those purple speech bubbles, it means I have a handout on that topic. And where I have green speech bubble, it means there's a lecture. So if you want to learn more about those topics, you can find that information on my website. So what is connective tissue? It's the stuff that connects us. By definition, it is a tissue where the stuff outside the cells is more than the cells themselves. So it's more extracellular stuff. And ligaments and tendons are kind of the poster child of connective tissue, where you have lots of collagen fibers that make it nice and strong. But it turns out that blood is a connective tissue as well. Fat is a connective tissue. Bone and cartilage are connective tissues. Now, in Ehlers-Danlos syndrome, because it's a collagen abnormality, not all of those types of connective tissues are affected equally. The ones that have more collagen, like ligament and tendon, but also the sheath, the protective sheath around nerves and blood vessels and organs. So certain tissues are more vulnerable than others. So there are 13, maybe 14 types of Ehlers-Danlos. They've just defined a new type. And it's gone through several iterations of naming. So you may have heard old names a long time ago. So Ehlers-Danlos type 3 was what was then called hypermobility type. Hypermobile type is the most common and explains 90% of all Ehlers-Danlos. And there is no genetic test for that one. There's a genetic test for all of the rest, but not for hypermobile. And I have lots of patients who say, I talked to my doctor, I said I had EDS. They said, well, you had a genetic test, and that shows that they don't understand hypermobile EDS, right? There is no genetic test for the hypermobile type. And that's what I'm going to be talking about most today. The next most common is classical. That's the one with the really stretchy skin. I'll show you a picture of what that looks like. And then I'm going to mention vascular because it is bleeding disorder conference. And that's the one that we worry about the most because that's the most life-threatening. If your blood vessels burst, if your organs burst, that can be life-threatening. So it's quite rare, but also you want to know. So these are some pictures of classical EDS. So classical EDS particularly affects the skin. You get that stretchy circus performer skin. You get wounds that don't heal well. So if you have a lot of skin issues, it might be worth getting a genetic test to see if you have the classical type. And then the vascular type. In the vascular type, the types of joints that are affected is different. So for hypermobile type, we'll go through which joints are affected, but elbows, knees, spine, fingers. But in vascular, it's almost always just fingers and toes. So they don't have hypermobility of the big joints. So they might not seem hypermobile at first. They'll have spontaneous bruising, very translucent, thin skin where you can see the blood vessels, early onset varicose veins. And I have asterisks next to those because a lot of hypermobile people have all of those as well. So don't panic if you bruise easily and you've got varicose veins. A history of internal or uterine rupture, now you need to be a little more cautious about it. And then there are these facial features. You can see over on the left some pictures of attached earlobes, narrow palate, deep set eyes. If there's any chance a person has vascular, you do want to get genetic tested. So hypermobility exists on a spectrum. On the low end of the spectrum, you have people who have what we call generalized joint hypermobility. They're flexible, they're double jointed, but they don't have any more symptoms than the average person, right? They might sprain an ankle every now and then, or get whiplash if they're in a car accident, but otherwise they're fairly normal. At the right side of the spectrum, the most severe symptoms are the people who have the other types of Ehlers-Danlos, other than the hypermobile type. In between, we've got this hypermobile type. And in 2017, there was a checklist, diagnostic checklist created, which I'll show you in a moment, for hypermobile EDS. And that can cover a spectrum of mild to more severe. However, a lot of people who are hypermobile and symptomatic and who had previous diagnoses of things like joint hypermobility syndrome didn't fit into the HEDS criteria. It was actually created because they were looking for a gene. It wasn't created to help diagnose patients. So those other people were named hypermobility spectrum disorder. Originally, there was an implication that hypermobility spectrum disorder was milder than HEDS and maybe didn't involve as many symptoms, and that's just wrong. Research now shows that they can both be equally severe, and there's not really much of a difference. So I'm lumping them together, and I'm just going to call them hypermobility or HSD. Okay. The diagnostic criteria are going to change pretty soon anyways, and they're going to be combined into one group. So how common is it? We don't really know because we don't have any population studies, right? You don't go door to door knocking on doors saying, can I see how stretchy you are, right? And asking if you're symptomatic. We do know it's the most common inherited connective tissue disorder. We think the overall prevalence of symptomatic hypermobility in the US is about 1 to 3%. So maybe 2 in 10 people, much higher in women than men. 80% or more are women. However, it is much more common in a healthcare environment because these people have lots of healthcare issues. So in a rheumatology clinic, a pain clinic, an orthopedic primary care clinic, it might be 1/3 of the patients are hypermobile, okay? So for all my colleagues who say, I don't treat hypermobility, that's a rare condition. I'm like, you treat it, you just don't know it, because probably 1/3 of the people who are in your clinic are hypermobile, okay? About 20% of pediatric patients. Now, in bleeding disorders, in a general bleeding disorder clinic that has 50% men, 50% women, about 1/4 of all the patients will be hypermobile. And that's compared to 2% of people who are matched controls, that is similar in age and gender, but didn't have a bleeding disorder. So it's much more common in bleeding disorders. In one clinic of bleeding disorder of unknown cause, BDUC, of the women, 80% were hypermobile. Okay, so we're talking about people like you. And even if you do have a known cause of a bleeding disorder, of von Willebrand's or hemophilia, hypermobility might make your symptoms worse. And that's what we're going to talk about today. This is a graphic of the different symptoms in hypermobility, and you can access it on my website, so you don't have to take a picture of it. I'm not going to read all the different symptoms, but you have connective tissue in every system in your body. Therefore, every system in your body might be affected by it. Not everybody has all the symptoms, but you may have any of those. And we have sort of 3 categories of patients, so sort of clusters. There are people who are mostly musculoskeletal and fairly mild involvement. We have those who are mostly neurologically involved, and then we have those who just have almost everything, okay, the complex patients. In terms of bleeding issues, easy bruising, heavy menstrual bleeding, excessive bleeding of the gums and nosebleeds, excessive surgical bleeding, excessive bleeding during childbirth, and GI bleeding. Sounds like what we've been talking about all day, right? So hypermobility is associated with all of those. And then, because this is a women's conference, I also added women's health issues, not specifically bleeding disorders, but women's health, so pelvic floor pain or dysfunction, dyspareunia, which is painful intercourse, and vulvodynia, so vaginal pain, incontinence, pelvic organ prolapse, and issues related to childbirth. So it's not just bleeding disorders that might be relevant to some of you, some of these other women's health issues may be. These are the diagnostic criteria that were created in 2017. I don't like them. I'll be straightforward about that. As I said, they're created by geneticists to find a gene. And so they were trying to be as narrow as possible, and they left out a lot of people who needed to be diagnosed. It's got 3 criteria. You can see the 3 sections, and you can access this online on the Ehlers-Danlos Society webpage. And actually, they have an app now that will walk you through all of this. So you can actually, it'll ask you all the questions, and you can print out a report and bring it to your doctor. But basically, you have to have hypermobile joints. You have to have signs of a connective tissue disorder or chronic musculoskeletal pain, or a first-degree relative who's been diagnosed. And that's problematic in a condition that is heavily under-recognized, right? That in my family, I've got 7 people who I know have EDS or hypermobile EDS, and none of them have been diagnosed, right? And that's just because the healthcare system hasn't gotten there yet, okay? And then no better reason for explaining your problems, okay? Hypermobility spectrum disorders, when you don't quite meet this criteria, mostly the connective tissue disorders, but you're hypermobile and you're symptomatic. So my criteria now, if you're hypermobile and you're in the PT clinic, you're symptomatic, you have HSD, okay? And treatment is exactly the same, whether you put the label HSD or HEDS on it. The diagnostic criteria are changing in December 1st. We are all waiting with bated breath, and none too soon, because the current diagnostic criteria are really rather unfortunate. Okay, this is the scoring system that we use for rating whether you have generalized joint laxity. And we're going to go through this as a group in just a moment. It's the Baton score. And it's also not perfect. It doesn't measure some of the joints that are symptomatic. It only measures joints in one body plane. But basically, we have pinky finger bending back past 90 degrees, thumb to forearm, elbows past 10 degrees of hyperextension, knees past 10 degrees of hyperextension, and hands on the floor, okay? And at the bottom, you can see 5 out of 9 is considered positive for your average adult, or for your adults from puberty to 50 years old. Us old fogies get stiff, and we can pass with a criteria of 4 out of 9. Kids are more flexible. They have to have at least 6 out of 9, and it can't be diagnosed in children under 5 because they're flexible anyways, okay? In the upper right-hand corner is the questionnaire. We call it the 5-item questionnaire for historical hypermobility. So people like me who, it's like I used to be hypermobile, but I've injured so many joints that they're not hypermobile anymore. And you can ask those questions, and if you answer yes to 2 of them, you can add a point, okay? But anybody who'd like to join, we're going to do this. So bending your pinky finger back, and does it go past 90 degrees? Okay, don't hurt yourself doing any of these things. And if you can't see, ask your neighbor to check. Thumb to forearm, so you bend your wrist down, and yeah, I'm seeing a few positive ones here, okay? Elbows extended. Now, you probably can't see your own elbows, so you might need your neighbor to look for you, but I'm definitely seeing a lot of hyperextended elbows. Okay. If you can do this without banging into too many things, you can stand up, check your knees, or again, have your neighbor check your knees. And then you guys all probably know whether you can put your hands on the floor. Okay. And so a score of 5 out of 9, or if you're older, 4 out of 9, or if you used to be hypermobile. Now, those aren't the only important joints. So you might not score 5 out of 9 on that and still have problems. Let's say your hands might be problematic, or your spine might be problematic. So as a physical therapist, I would measure other joints as well, whatever joints the patient is having issues with. Okay, so your neck should not be able to bend 90 degrees in any direction. It should not rotate more than 110 degrees. You know, those are things that are extreme. But you can also see that hypermobility can be a benefit to ballet dancers and ice skaters and gymnasts and actually musicians as well. Hypermobile fingers help them to be more facile on their instruments. They are going to add a couple of joints to the Baton score, and it's going to be the shoulder, the forearm, the ankle, and the big toe. And I think part of that is those are joints that are less likely, well, not except for the shoulder, the other ones are less likely to lose range because they've been injured. There is a different set of criteria for children. So if you have a child you think might be hypermobile, there's a different set of criteria, and that's available on the Ehlers-Danlos website as well. Now, hypermobility tends to exist in what we call the terrible trifecta with postural orthostatic tachycardia syndrome and mast cell activation syndrome. And I'll define those a little bit more in a moment. But we think probably about 70% of people have all three of them in one amount or another, with the exception that since COVID and long COVID is mast cell activation plus POTS, now there's a lot of people who aren't hypermobile who now have mast cell activation and POTS. And you can see from this Venn diagram, there's a lot of symptoms in the middle that overlap, and that makes it really challenging to treat. The person comes in and says, well, I hurt, and I'm weak, and I'm tired, and I've got diarrhea, and I've got headaches, I can't sleep. And I'm like, yeah, well, it could be any of those three conditions. So it can make it challenging to treat it because you don't know which of those three conditions is causing those particular symptoms. And worse yet, the three conditions tend to aggravate one another. With the mast cell activation, so it's an inflammatory condition, it probably causes or aggravates the instability because it makes your joints more unstable, and it probably aggravates the POTS by irritating the nerves. So a little bit more about those two conditions. So dysautonomia is the more general category for POTS. Dysautonomia means your autonomic nervous system is not working properly. So your autonomic nervous system controls things like your heart rate and your breathing and your digestion and your peeing and your kidney, all those things that happen automatically that you don't have to think about. And pretty much everything between your head and your butt is controlled by your autonomic nervous system. And you can see the different systems and symptoms that might be affected by it. Most dramatically, it's what we call orthostatic intolerance, which means when you're upright, you tend to get woozy, dizzy, lightheaded. The world might disappear and come back. And you'll feel a little bit better when you lie down. That's orthostatic because it means it depends on your position. The cardiovascular symptoms, the tachycardia, which is a fast heart rate. What happens is you go to stand up, blood starts pooling in your feet. You don't get blood to your brain. Your brain needs a lot of blood, and one of two things will happen. You'll pass out so that you're horizontal, so it's easy to get the blood to your brain, or your heart will start beating really fast to pump the blood up to your brain. And that's the tachycardia, the fast heart rate. Or palpitations. And it was interesting at the last lecture that iron deficiency anemia causes some similar things. So I'm going to have to start looking for that in my POTS patients who don't respond to treatment. The autonomic system also controls your gut, and so a lot of gastrointestinal problems. So should you suspect POTS? Well, if you find that your heart races, it starts beating fast when you're not doing anything, you're just sitting there and it starts going bump, 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 bump. Or if you get dizzy and woozy when you stand up, when you first stand up, or if you've been standing for a while, or if you're just really fatigued and you can't find another reason for it, you might have POTS, so you can look into it. It's pretty easy to diagnose. Any doctor's office can do it. I would do it in the PT clinic. We do it using what's called a tilt table test or a stand test. Basically, you lie down, we take your heart rate and blood pressure. We get you to stand up completely still, because any kind of fidgeting is pumping the blood up to compensate for it. And then we measure your heart rate and blood pressure for another 10 minutes. And if your heart rate goes up and stays up for at least a couple of minutes, then you may have POTS. And it has to go up at least 30 beats per minute for an adult, 40 for a child, because they have higher heart rates to begin with. And if your symptoms are worse when you stand up and better when you lie down, although symptoms don't go away immediately when you lie down. So if you're thinking, oh, I stood up and I got this blasting headache and I lie down and it's not gone in a minute, it's like it could still be POTS. Okay. And if you're interested in more on POTS, I have a lecture on POTS and some handouts on my website if you want to learn more. So mast cell activation. Mast cells are non-specific immune cells, so they just react to anything that they believe shouldn't be there, okay? So they're particularly sensitive to the outside world. So your skin, your respiratory tract, and your gut, which all are exposed to the outside world, are very reactive. And there are mast cells in all of the tissues, so any tissue can become inflamed with mast cell activation. And the mast cells will release things like histamines, and you know that from antihistamine ads that your sinuses get congested, but any tissues can get congested. And this can be particularly relevant for excessive menstrual bleeding, because if your uterine tissues get congested with blood, then there's more blood to bleed and there's more bleeding, okay? We believe that mast cell activation can actually increase the hypermobility. We believe that it may actually degrade the connective tissue, that the inflammatory chemicals, the inflammatory soup might actually make people more unstable. We also believe that it can increase bleeding. So mast cells, in addition to releasing histamine, release heparin, which is a blood thinner, and they lead to leaky blood vessels. So a couple of other reasons why they can contribute to bleeding. It's much harder to diagnose definitively. So the first and third criteria are pretty easy, that you have symptoms in at least two of those systems that I showed you before. So let's say your gut and your skin, or your nervous system and your gut, your respiratory tract and your skin, and you respond to mast cell medications. So walks like a duck, talks like a duck. The second criterion is the troublesome one, that they want to do a blood test. The problem is the blood tests have like a 98% false negative rate. So they can do the blood test like 20 times before it comes out positive, even when the doctor knows you have mast cell activation. So as a proxy, there's a questionnaire that you can fill out. It's available at this link, and the handouts have all the links are active. So if you want to access those links with the PDF, just email me. And it'll ask you a bunch of questions about symptoms. And if you score 14 or more, that's associated with having mast cell activation disorder. Are you okay? Okay, nope, just as long as you're okay. So that's a good way to figure out if you have mast cell activation. If you think you probably do, the definitive diagnosis is really, really difficult. So if people with hypermobility have so many symptoms, what are we going to do about it? So this is what's called a spider plot, because it looks like a spider web. And it shows the 8 primary areas where people may have symptoms. So NMSK is neuromusculoskeletal. So feeling unstable, having your hips slipping in and out. There's pain, fatigue, gastrointestinal symptoms, cardiac dysautonomia, like the POTS we were just talking about, depression, anxiety, and urogenital symptoms. And if you wanted to figure out where your problem areas are, the questionnaire, there's 31 questions, and it'll plot you one of these little spider plots, okay? And the website there will get you to an Excel file where you can do that. And sometimes that's helpful, because patients will come in and it's like, well, I got this problem and that problem and this problem and this problem and this. It's like, where do I start? Well, this tells me on this particular person, I might start with fatigue and their neuromusculoskeletal issues, okay? So it helps us to organize our thinking when it's such a complicated problem. Now, not everybody with hypermobility has pain. The picture in the upper right, if you're my age, you'll recognize Michael Phelps, the Olympic swimmer. And if you look at that elbow, that is hypermobile, okay? But he obviously didn't suffer from it. He was pretty fit. The young woman at the bottom, the gymnast, at least doesn't yet have pain. So not everybody has pain if they are hypermobility. Hypermobility and instability are not quite the same thing. Hypermobility is just how much motion you have. Instability is whether you can control that motion. So if you're wobbling around, if your hip is slipping in and out, around that neutral zone. So your hip is slipping, but it's not going to its end range. You're not stretching it, it's just slipping around. And so why are people who are hypermobile more likely to have problems? Well, we have poor body awareness, so joint awareness. We call that proprioception in physical therapy, because some of the nerve endings that tell you where you are in space are in the joints, and the joints are stretchy, and so we're getting bad information, right? It's like having, bad Google Maps. Poor motor control. If you're not able to access the correct muscle at the correct time to hold you in the correct place. So people who are hypermobile tend to sort of have this all or nothing, that they're like, oh, you want me to move? They don't have a gradation from 0 to 10. They just have on and off. Having the joints in the fascia getting wiggled around, put stress on them. Overworking the muscles, that muscles will tense up, trying to provide support. For example, that leads to a lot of pelvic floor problems, because the pelvic floor muscles will tighten up trying to hold your pelvis together, or trying to hold your lumbar spine in place. Well, that's not the job of the pelvic floor muscles. And so they're doing too much work. And so they may have problems because of that. Just gravity pulling on joints. And then muscle spasm or fascia contracting, because if you're anxious or stressed out, which you could be if you keep subluxing joints, then that sympathetic activity or fight or flight response makes muscles get tense. Okay, so there are a lot of different reasons why we can have musculoskeletal problems. And the more you understand, the better you can take care of yourself and try to minimize those problems. So bleeding issues, in the past 10 years or so, research has been coming out. So this particular study looked at the prevalence of different bleeding issues in a group of people with hypermobility. So menorrhagia or heavy menstrual bleeding was top. Excessive surgical bleeding, skin bleeding, nosebleeds, minor wounds, dental bleeding. So we've been talking about all those things today, and for hypermobile people, they have a pretty similar pattern of bleeding as what we've been talking about. If you do a BAT, the bleeding assessment tool, about 70% of people with hypermobility will score in that, yes, you have a bleeding disorder level. So it's not just a minor complaint, but a significant problem. And people with hypermobility are more likely to fall into the bleeding disorders of unknown cause category, simply because they don't necessarily have von Willebrandt's or hemophilia. It's all these other things that are contributing to the bleeding. Problem in our population, I don't know if it's a problem in your group, but the implication of domestic abuse or child abuse, because of all the bruising that can happen, unfortunately occurs, that children have been taken out of the home because, it's like, how could a, 3-month-old baby get all these bruises on them? It's like, well, they're hypermobile. I mean, you can't diagnose it at 3 months, but anyways. So, and then the mast cell activation that we were talking about also leads to bleeding because it releases the heparin, and it causes the blood vessels to be leaky. So there are a couple of reasons. Heavy menstrual bleeding affects 76% of women with hypermobility, and is often the most distressing. As we've heard here, it's a significant problem, and it's severe enough to lead to hospitalizations and surgery, and hysterectomies. And once I started looking for bleeding disorders, I realized that of my adult women patients, half of them complained of heavy menstrual bleeding, and the other half had had hysterectomies because of heavy menstrual bleeding, sometimes hysterectomies in their 30s. Okay. And there's a study that shows that people who had undiagnosed EDS were 50% more likely to get a hysterectomy than somebody who had von Willebrand. So if they say, oh, you have a bleeding disorder, let's look at some other ways to manage it, they don't just take, the uterus out, right? And so it's important in my community that patients with heavy bleeding get assessed for a bleeding disorder, which doesn't always happen. Okay, so why is there excessive bleeding and hypermobility? A couple of mechanical reasons, a couple of bleeding issues, and a couple of mast cell issues. So first, Connective tissue is the packing peanuts that protects our organs and our blood vessels. And our connective tissue is weak. And so the blood vessels don't have the protection. So if you bang into something, the blood vessels are more likely to be damaged. The blood vessels themselves have connective tissue in them, which is defective. So they are fragile. They are more likely to be damaged or torn. Okay, so you bump into something pretty lightly and it causes bruising. Well, it shouldn't, blood vessels shouldn't be tearing quite so easily. We also have abnormal platelet function. So there's collagen involved in that platelet cascade. So we have abnormal platelet clotting, which, as you know, is part of what stops bleeding once you start bleeding. And then mast cell activation, because it's an inflammatory process. You can imagine, your sinuses getting swollen. Well, it engorges the blood vessels with blood and makes them more leaky and releases heparin. So now you have blood vessels that are really full, that are leaky, and you've got more heparin in your system. And this is probably particularly important for the heavy menstrual bleeding because the mast cell activation probably causes engorgement of the blood vessels in the uterus, and of course they're sloughing off, and so now you just have a lot more blood there that's coming out. And I think this is helpful to know because you might not think, I wonder if I should try managing mast cell activation to see if it helps with my bleeding, right? It won't work for everybody, but it might work for some people. So why is it important for people with bleeding disorders to recognize hypermobility? Well, kind of like you, we take a long time to get a diagnosis. Okay, 17 to 22 years on average, like 10 providers telling you that there's nothing wrong with you, you're just overreacting, you're just anxious, you're just a fretting woman who's got nothing better to do with her time than see doctors. And so if I can help any of you guys get there sooner, that would be good, right? And we know that 1 in 4 people with bleeding disorders overall, and 80% of women with bleeding disorders of unknown cause are likely to be hypermobile. It may help people get an opportunity to manage some of the other issues other than the bleeding disorder that are associated with hypermobility. That, the POTS, if you've been experiencing, oh my God, I get dizzy all the time and I pass out, I almost pass out. And, that's something that can be managed once you know what it is, okay? There are increased surgical risks and suture needs for people with hypermobility, which we'll go into in the next hour when we talk about treatment. And managing the bleeding might turn out to be a little bit different. We don't know because we don't have actually studies in the management of bleeding disorders in people who are hypermobile. We're starting to know that these people exist. But my example of if you have mast cell activation that's causing, increased menstrual bleeding, maybe treating the mast cell activation might be helpful. Surgery precautions, I guess I've got it here as well. So surgery, orthopedic surgery in general is only half as successful in people who are hypermobile, and the risks are much higher. So you always want to be a little more cautious about getting a surgery. So let's say you have an unstable shoulder, the doctor's like, yeah, we can fix that. We're just going to do a, Bankart maneuver, fix your, it's like you only have half the chance of improving after the surgery compared to a non-hypermobile person. Think about that. And you have somewhere between twice the chance and 80% higher chance of having complications associated with the surgery if you're hypermobile. So just think about it, okay? Tissues are more fragile. The blood vessels are more fragile, and there's a risk of dislocating joints during the surgery. They pull your arm out here to put the IV in, and that's fine for a non-hypermobile person, but it might dislocate the shoulder of another person. And then precautions for dental bleedings. And there are also some precautions for anesthesia. So again, I've got a handout and a lecture if you want to learn more about that in particular. So hypermobility is a common connective tissue disorder affecting primarily women, but not only women. It is associated with increased bleeding. It is important among my colleagues that we recognize the bleeding, but then for you guys to recognize if and when you're hypermobile, okay? That can potentially improve your self-care and your management. We'll be talking about that in the next hour of what you can do about the hypermobility. And it might help you to look for the POTS and the mast cell activation, which might be contributing to some of your other health issues. Hypermobility, because connective tissue is everywhere and the symptoms can be so complicated, the saying that we often use is when you can't connect the issues, think connective tissues. So when somebody comes in and says, well, I've got joint pain in my shoulder and my neck and my hip and my toe and my GI, I've got really bad, constipation, and I keep getting recurrent urinary tract infections, and I've got TMJ pain and migraines. It sounds like a lot of different things, but all of those could be associated with hypermobility. And so sometimes it's one explanation that helps you to understand a lot of different issues that you might have. Some resources here. So as I said, I've got handouts and additional lectures on my website. The Ehlers-Danlos Society has excellent resources. If you want the spider questionnaire, that's available. And like I said, the slides, all of these links will work. You can just click on them. Bendy Bodies is a really awesome podcast where she interviews experts on different aspects. I have lots of references. And then we have plenty of time for questions.
People with lipedema also being associated with hypermobility.
Lipedema?
The lipedema, yeah,
Yes.
sorry, yeah.
So that's a great question, and it's new enough that I haven't added it. Hello.
But I'm just seeing a lot more talk about it.
Yep.
Have been making
Yep.
I feel like
Yep. Yep. So I actually wrote an article probably almost 20 years ago now. Is it really fibromyalgia? When it wasn't fibro, it was either hypermobility, POTS, or mast cells. So if your body hurts all over, you might be hypermobile. If you're tired all the time, you might have POTS. And if you're super sensitive to everything like perfumes and medicines and you react to every drug you've ever tried, you probably have mast cell activation. If you put those three together, it looks exactly like fibro. And in the time before EDS was being diagnosed, so the first 20 years of my PT career, most of my hypermobile patients came to me with a diagnosis of fibro. And half of them did have fibro as well as being hypermobile. If they were 30 years and younger, they almost always had hypermobility instead of fibromyalgia, which is an important distinction because the treatments are different. But getting back to your other question on lipedema. So for people who aren't aware, lipedema is when you tend to store lots of fat in certain places and you get that puckering of your skin. And it's another connective tissue disorder. The fascia is sticky in certain places and leaky in other places. And you get that sort of gnarly texture to your skin. And yes, that is increased in hypermobility as well. And we're just starting to recognize it, and we don't yet know what to do about it. Yep. So, and they asked me to repeat questions. So the question was, is it just that the collagen fibers aren't sticking together properly? And the answer is yes. And that's why people with hypermobility have more ulcers or hernias, right? That, we split, we pop out. And even in the skin, you get little things popping out. In the central nervous system along the spinal cord, you get these little pouchings of things because the connective tissue is weaker. And so, yes, the connective tissue that normally holds us in is weaker. And so bits of it are poking out. Yep. So from that point of view, it's mechanical. We don't know whether mast cell activation might be contributing through inflammation. It's still a new area. Yep. Other questions? Yep. Venous insufficiency? Are you talking about venous insufficiency in the abdominal area or legs? So venous insufficiency can be associated with hypermobility. The two most common locations for venous insufficiency, one is in the abdominal area where you may have pelvic congestion syndrome, where something squeezes on your veins and you can't get blood back up to your head, so you get congestion. It's usually in the left lower abdominal area. It can cause very severe pelvic pain and swelling, particularly in the left side. And then there are venous congestion issues in the brain because there are veins in the brain that may get squeezed shut. And of course, the fluid, the cerebrospinal fluid in the brain needs to be able to drain out properly. So venous congestion can be a problem. Things like varicose veins for sure are a problem. That can also then contribute to poor wound healing as well. Yeah. Headaches? Yes. That was the other way that I got most of my patients who are hypermobile is headaches, and I have a whole lecture on headaches. So there are several reasons why headaches might be more common. One is cervical instability, and it might not be the cervical instability so much as the muscles tensing up trying to prevent cervical instability, and those muscles can develop trigger points that cause headaches. But then it also turns out that POTS in itself is a trigger for migraines because it controls blood flow. And mast cell activation is separately a trigger for migraines because it affects inflammation. And migraines are actually excessive histamine in the brain. And so there are glial cells in the brain, which are like your mast cells. And when they release histamine, that can trigger a migraine. So yes, headaches and migraines are both very common in people who are hypermobile. And again, it gives you some ideas of how you might treat it. That if I'm hypermobile and I have a headache, it's like, well, let's work on posture. Let's work on being stacked up properly, not looking at my phone like this, that it gives you some more ideas of how you might treat it to prevent the problems rather than just medicating the pain. Do I get migraines when I stand up? Well, maybe that's a POTS issue. Do I get migraines when I eat cured meats? Well, maybe it's a cell issue. And so it gives you more ideas for ways you might be able to manage it. And then there's jaw pain, which I could talk about for a whole nother hour. And the trigger points? Yes, okay. And I'll talk about this a little bit in the next hour when we get into treatment. And I got a whole lecture and a handout on trigger points. So muscles can develop what we call trigger points, and it happens to be where the nerves connect to the muscle. And if that area gets irritated, it can refer pain someplace completely different. Okay, so this muscle right here, the sternocleidomastoid, refers pain in exactly the same pattern as a migraine. It can also lead to sinus congestion, dizziness, nausea, ringing in your ears. And so there are other symptoms besides just pain. And there are certain patterns you can look for that the patient came in to me and said, I've got a migraine and I've got ringing in my ears and my sinus feels congested. I would go poking around that muscle. And if they were like, ooh, then it's like, oh, it might be a trigger point in that muscle. So if the muscles are working too hard and they develop those trigger points, which is kind of like muscle spasm, but a little bit different, then you want to decrease the stress that's causing those muscles to develop those spasms. It can cause pain and swelling in the neck. There are trigger points that can make it feel like a heart attack. That I've had patients come in and say, I spent the weekend in the emergency room. I thought I had a heart attack. And I'll poke around. There's some muscles in here called the scalenes, and they refer crushing chest pain. So yeah, trigger points are a whole nother category. But I do have headache. I have a handout on headaches in particular on my website if you want to learn more about that. Yeah, and we'll talk more about treatment in the next hour. Other questions about recognizing any of these conditions or?
No, it was 29 right before COVID. They did the tilt table test, all the stuff, and the cardiologist stamped yes POTS, but I see an autonomic doctor now, and he's questioning whether or not I actually do have POTS and trying to rerun all the tests that I already did before. Is that like a common thing, or?
Okay. So, yeah, having a POTS test. So having POTS is a predisposition. The symptoms of POTS is kind of like being dehydrated. You might be dehydrated one day, but not the next day. So when I have a patient who needs to have a POTS test, I'll tell them, stop doing everything that's good for yourself, drinking lots of fluids, wearing compression stockings, getting electrolytes, because if you are managing your POTS, the test will come out negative because you are managing your POTS. And so that may be the difference, is that the original test, you were naive that you weren't managing your POTS. It came out positive. Now you are doing all the right things so you don't have so many POTS symptoms. It's not like a genetic disorder that's going to always be there. You only see it when it's acting up. And so the test may come back negative, but you still have the predisposition for POTS. If you stop doing all the good things for yourself, then the symptoms are likely to come back. So you can't really tell a person who had POTS that they don't have POTS. You can only say, you don't have the symptoms of POTS right now. Good for you. You're managing it well now. Okay. But yeah, I've had patients who, they go to the doctor and, they get tested, but they've already spent 2 months doing all the things I've taught them to do to take care of themselves, and the test doesn't come back positive. And you'll see guidelines online will tell you that you have to stop taking any medicine you're taking for your POTS. Stop drinking lots and lots of water. Stop with the electrolytes. Don't wear your compression stockings. And of course, you're like, it's going to be a bad day, right? But that's what would make them see the POTS still. So that's a great question. Yeah. And then there are the cardiologists who say POTS isn't a real thing, which is really frustrating. It's not a real heart disorder. It makes your heart function abnormally. It's a neurological disorder, but if your heart's not functioning properly, the cardiologist should at least acknowledge that it's real.